Today we're going to be covering a specific topic on ankle sprains, the types of ankle sprains that tend to occur, some of the mechanisms of injuries, specifically how rolling your ankle or everting it will cause damage to specific ligaments, tissues, and even osseous structures. I'm going to give you kind of a non-typical case in this situation on what may occur, some of the findings and some of the radiology reports and some of the things that we may see, so you can know how to better handle it, how to go into it, knowing what to expect, some of the signs and symptoms of an ankle sprain, so that way you know what type you may have. So here we have a 18-year-old female that presents with complaints of right ankle sprain. It has been going on for about 1 month duration. The injury occurred when the patient was running around her car and slipped, suffering an eversion type of injury. She went to the local ER on that day of injury. So some of the things that we can ask ourselves is, what exactly is the difference between inversion and eversion? What would you expect to see in the patient's presentation? And what procedures would you expect the ER to take? So here we have a eversion versus inversion type of sprain. So as we can see that on the inversion side, it's kind of a sprained lateral of the ligaments, kind of a normal. And then here is what would be a eversion, which is sprained on the middle or medial side. So something that they kind of use a lot are what they call the Ottawa rules for foot and ankle radiographic series with patients in acute ankle injuries. So these are kind of just the rules of what would follow. These are just kind of the rules of what would need to happen in order to order an x-ray of the foot when talking about an ankle injury, specifically an ankle sprain. So an ankle radiographic series is required only if the patient has pain in the malleolar zone and any of the following findings. So that would be bone tenderness at the posterior edge tip of the lateral malleolus. I'll kind of go over all these areas in a bit. Bone tenderness at the posterior edge of the tip of the medial malleolus, and the inability to bear weight both immediately and and the last one is inability to bear weight both immediately and in the emergency department. So bearing weight is just kind of standing on your foot. You feel like you're going to collapse. Your body's kind of stopping you from that using, the pain response. Now the other series where it would be ordered, where is a foot radiographic series, is required only if the patient has pain in the midfoot zone and any other following findings. So bone tenderness at the base of the fifth metatarsal. So it's kind of the base of where your little pinky toe is on your foot, a little bit lower than that though. So bone tenderness at the navicular, and the inability to bear weight both immediately and in the emergency department. So here we have an eversion sprain covering the certain aspects of what we might see and some issues in the areas. So here we have an eversion sprain, and it's kind of showing you the medial or the middle side of the foot if you're looking at it from between your feet and your foot was put on like a stand. Some of the common symptoms that we may see is immediate pain on the inside of the ankle, rapid swelling or bruising, difficulty with bearing weight, and limited ankle mobility. So pretty much you just can't move it. You have a tough time putting weight on it. There may be some swelling or bruising depending on what type of ankle sprain you have. So here's covering the inversion sprains. Some of the symptoms are similar. Limited ankle mobility, pain on the lateral aspect of the ankle, bruising may or may not be present. Like I said, just depends on which type of ankle sprain you have, and pain with bearing weight are the most common ligaments that will be affected with a inversion ankle sprain. So you kind of just roll your ankle out, so you're kind of placing and kind of rolling it out that way, or rolling it in that way, I'm sorry, would be the first one that's most commonly affected is the anterior talofibular ligament and the calcaneofibular ligament. And it's most common, and it's important to note that 90% of all ankle sprains occur to damage to these two ligaments. So if you do have an ankle sprain that is inversion mechanism of injury, these are most likely the ligaments that will be affected. Now, the one that's less commonly involved is the posterior talofibular ligaments. These are just tend to be a little bit stronger. You can see that the bands are a little wider, and that it's not in an area that you would roll easily or hurt easily if you did roll your ankle. So kind of going over the types of different grades for ankle sprains by their grade. So we can see that grade 1, the tendon doesn't have any tears. The loss of function of ability is minimal. Pain minimal. Swelling minimal. Ecchymosis, that's just another word for bruising. It's usually not present. And then difficulty bearing weight, they don't have any difficulty bearing weight. Now grade 2 is where we see a partial tear in any of these ligaments. Some loss of function. Pain is moderate. Swelling is moderate. and there tends to be frequent bruising in the area. And sometimes they usually have difficulty bearing weight. Now, grade 3 is where we have a complete tear of any of those tendons. They lose a lot of function. The pain is severe, swelling severe, lots and lots of bruising, and almost always do they have difficulty bearing weight. Here we can kind of see for the eversion injury for our case that we had earlier, you'll see some swelling, some in this area. So we can kind of ask ourselves what atomic structures may be associated with eversion sprains. So the medial malleolus fracture for Hawkins type fractures, deltoid ligament, which is a really strong ligament, but in eversion sprains, it can be damaged or torn. Ankle syndesmosis, which is common with high ankle sprains. It's the connective tissue sheath that connects the fibula and the tibia, or the fibula and the tibia. The ankle syndesmosis is a high ankle sprain, and it's usually that connective tissue that connects the fibula. So we can ask ourselves what atomic structures may be associated with eversion sprains. So the medial malleolus could be fractured, and that's usually associated with what they call a Hawkins type fracture. The deltoid ligament, it is a strong ligament. It tends to not be easily damaged, but when it does, specifically on eversion injuries, it can be detrimental to the function. It can be detrimental to the function of the foot. The ankle syndesmosis, which is a high ankle sprain, and it is the connective tissue that connects and stabilizes the fibula and the tibia or spring ligament. So some of the things that they might do at the emergency room when people go in is they'll get some plain films. We'll have some of those to come. They'll make the diagnosis of an ankle sprain. They'll usually provide a patient with crutches and an air cast stirrup brace, kind of something like this. And then they'll have you follow up with your PCP or your primary care physician as a recommendation. So as we can kind of see that 3 weeks later, the patient presents to her PCP. She is slowly improving but has persistent right ankle pain. The official read on the x-rays at the hospital show an ankle fracture. So as we can kind of take a look here, we can kind of see that we don't see much on the anterior side, but the lateral side does show us fracture of the neck of the subtalar joint. Or I'm sorry, on the lateral view, we can see that we have a displaced talar neck fracture with subluxation of the subtalar joint, kind of the open arrow, kind of seeing it displaced. And then we can see the actual fracture here. What is the Hawkins classification for talus fractures? So a type 1 will be a fracture of the talar neck with no displacement. The type 2 will be a fracture of the talar neck with subtalar dislocation. So we can kind of see that here. And then type 3 is a talar neck fracture with subtalar and tibiotalar dislocations. And then type 4 is, one of the most severe ones. It is a talar neck fracture with subtalar, tibiotalar, and talonavicular dislocations. So here we kind of have some of the talar body fractures, the common incidence between them, and then the mechanism of injury. So if it's the dome of it, it's usually inversion, eversion, or rotation, and usually crushing or shearing would be the most common group of them, but that's usually with axial compression or shearing, so kind of jumping off a roof or kind of jumping down from a high surface. So kind of now back to our case here. So the patient is seen 1 week later in an orthopedic sports medicine practice. She's now 4 weeks post-injury. So the presentation, she's walking on her foot with slight antalgic gait. She denies ankle pain, complains of mild ankle stiffness with plantar flexion and dorsiflexion. So plantar flexion being toeing off and dorsiflexion putting your toe to your nose. So the review of systems is otherwise negative. So she doesn't have anything else going on. And then there's no significant past medical history, no prior history of right ankle injuries. So what would be the next steps in the physical exam? So normally they'll kind of get your vital signs, make sure that there's no red flags going on. So right here we have a healthy appearing female, normal body habitus, right ankle showed mild ankle swelling, no deformity, reduced active and passive range of motion in plantar flexion and dorsiflexion, inversion, and eversion, so she really can't move it too much. Mild tenderness across the talar neck area and anterior joint line. Remainder of the foot was non-tender, sensation was intact to light touch to all dermatomes. She has a 2+ dorsalis pedis and posterior tibialis pulsus. So kind of just measuring to see if there's any issues with the blood flow, the vascularity, and just kind of making sure there's nothing going on blood-wise, and we'll kind of get to that in a little bit, a reason why. So kind of thinking about what is our other types of differential diagnosis. Obviously, we suspect a Hawkins type 2 talar neck fracture based on the radiology report, medial malleolar fracture, talar osteochondral lesion, anterior process of the calcaneus fracture, synovitis, medial ankle sprain, high ankle sprain, and tibialis anterior tendinopathy. So They repeated the x-rays. They were obtained in the orthopedic office. So repeat x-rays were obtained in the orthopedic office to further assess the fracture. So we can kind of see that it is healing based off of our previous side, and we can kind of see that it is healing a little bit there and kind of see it's kind of coming together. So what do you think the purpose of retaking films is? The primary purpose of this is just to make sure that there's nothing going on that is a red flag. So primarily avascular necrosis. That's kind of when the blood supply to that bone is no longer there, and then the bone will disintegrate because it's not being innervated or supplied by blood. And that's when it becomes a very big issue. So we can see subtle shortening of the talar neck with faint fracture line through the neck of the talus extending diagonally to the subtalar joint without significant dislocation. So in the initial report, we had a Hawkins type 2 talar neck fracture with 18 millimeter displacement at the subtalar joint, posterior facet causing nearly 100% dislocation of the talar body. And in the secondary report performed again, we had subtle shortening of the talar neck with faint fracture line through the neck of the talus extending diagonally to the subtalar joint without significant dislocation. Kind of ask ourselves what's kind of going on here. So in a case like this, they'll often order a CT of the ankle to make sure that there's nothing else really going on, that there's something kind of a red flag sign. So in this case, we can see the CT results confirm that the oblique fracture through the talar neck with minimal displacement anteriorly. The fracture measures 1.4 millimeters with no subtalar displacement. We can also see early bone bridging across the fracture site, which reflects some degree of healing. So it is healing, and that's kind of why we don't see that displacement. So the patient was referred out to orthopedic surgical management, typically via surgical stabilization. So our working diagnosis is Hawkins type 2 talar neck fracture or dislocation with apparent self-reduction by ambulation. So some things that we'll see very often is that she's 18, she just wants to get back to work. You know, being 18 years old and being kind of handicapped with crutches is a very difficult situation for most people. So something that will commonly happen is the patient did not, in fact, see the orthopedic surgeon following her CT. Rather, she wound up rescheduling the appointment for 2 weeks later, so 6 weeks post-injury here. And for the presentation, we can see the patient is non-compliant with previous non-weight-bearing instructions. She wasn't listening. She wasn't putting, she wasn't wearing her crutches. She was still putting weight on it. The patient denied having pain, and she requested a return to work note from the office so that she can begin waiting tables again with no restrictions. So when we did our examine again, we found that examination found normal gait with no tenderness to palpation of her right foot or ankle. Range of motion found 5-degree reduction on dorsiflexion and 5 to 10 degree reduction on plantar flexion with mild subtalar stiffness. So kind of what would happen now, what are the recommendations that would be made, and what do we need to keep an eye out for? So X-rays are retaken to ensure that the fracture is healing, which it is, and to make sure the avascular necrosis has not occurred. So kind of concluding here, the patient was released to all activities with no follow-up needed unless ankle pain resumed. 2 years post-injury, the patient continues to do well and denies any right ankle pain. So here we kind of have a situation where, yes, I didn't go for orthopedic consultation to make sure everything was okay, and it did heal because they were pretty young, they were pretty fit, pretty healthy, but the repeat x-rays were necessary to make sure that the bone was healing correctly, it wasn't displaced, there weren't any issues with the range of motion, the function of the foot, and then primarily the main issue was to make sure that there wasn't any avascular necrosis, and in this case there wasn't, and it did heal okay. So kind of some side comments. Talar neck fractures are rare but have a high risk of complications. They typically occur through pronounced or severe dorsiflexion, so kind of flexing your foot up really high, such as car accidents or a fall from a height. Sports injuries such as snowboarding or other precipitators. Sports injuries such as snowboarding are another precipitator. So about 10 to 15% of these talar neck fractures risk developing avascular necrosis in Hawkins type 1 fractures. And in this case, a Hawkins type 2 nalar fracture has a 20 to 50% risk of developing avascular necrosis. That's why so many repeat x-rays were performed in this case. So due to the high risk of AVN, standard care is for urgent reduction of the dislocation and immobilization. That's why they recommended her to wear the splint or wear the brace that they gave her at the hospital and use the crutches. Surgical fixation is recommended for Hawkins types 2 through 4. In this case, they did heal on its own, but it's a 50-50 shot in this case to make sure that it didn't happen. So it didn't happen for her, but it could happen in the future if they do fracture it again, or if something occurs to someone else who's not as young or physically fit as this individual was. We do remember she was 18, so she does have the ability to heal and replace bone a lot quicker than most individuals. And here's kind of some of the citations that we have for the whole thing here. So here we can kind of see that we have the right ankle, kind of the diagram, or the right foot here. and we can kind of see the different ligaments. So like the anterior talofibular ligament is here, which is the first one that's primarily injured, and then we have the calcaneofibular ligament, which is these two ligaments that 90% of the injuries occur in when it is an inversion ankle sprain. And then the last one, we have the posterior talofibular ligament, which is the one that tends to not be commonly involved, but it can happen in severe cases of ankle injury. We kind of see the lateral side, or the medial side, I'm sorry. And with them, we saw a fracture right around there. So that was the main issue that was kind of going on there. So we can kind of see that fracture. There we go. You can see a little bit better. That was on the talus. So kind of just give you guys a better understanding of what's kind of going on, what's some of the issues that's going on with it, and what's can caused by avascular necrosis in some situations. I want you to put that between inversion sprains and physical findings in ankle sprains here. So hopefully this was some insight into learning about certain types of ankle sprain injuries, some of the mechanisms of injuries, what to do, what will most likely happen if you do go to the emergency room, some of the post-operative care if it was needed, some of the conservative care that may be needed. So if this video was helpful and informative, please like, share, comment, and subscribe, as it is the best way to support our channels. Thank you, and I hope you have a wonderful day.